I'm Dr. Sarah Cate. I'm a breast surgeon at Mount Sinai, and I'm director for high risk across the Mount Sinai health system. So there's three different options for patients facing a mastectomy who choose to have reconstruction. So the first option is always that you can opt for no reconstruction, which patients may choose for a variety of different reasons, and it's a very personal choice. The other option is what we call implant-based reconstruction. So a lot of centers do tissue expanders, which are like a plastic bag, and that gets filled with fluid and eventually gets exchanged in a second outpatient or ambulatory surgery for an implant. At Mount Sinai, we typically do direct to implant reconstruction, which means that the implant is actually placed at the time of the mastectomy, and there's not a need for a tissue expander if everything looks good with the mastectomy flaps. The third type of reconstruction, which is also very popular at Mount Sinai, is what we call autologous breast reconstruction. Autologous breast reconstruction means that we'll use tissue from your own body. So many patients may have a little extra belly fat. And so how that's utilized is, and then the blood vessels and the fat is brought up and made into a new breast. So it's a really excellent way to use your own body to reconstruct the breast. And many patients opt for this because it's covered by insurance, and it allows them to have a little bit of a cosmetic surgery, meaning the abdominoplasty or the tummy tuck, at a time where they're facing a really difficult choice to undergo mastectomy. Sure. So candidates for breast reconstruction are essentially any patient that's undergoing a large lumpectomy or a patient that's undergoing mastectomy, and that can be on one side, which is called a unilateral mastectomy, or on both sides, which is a bilateral mastectomy. And so we offer it to all patients that we know may have a cosmetic defect. And so it depends on your goals in terms of your relationship with your breast and how you'll feel about yourself afterwards. Many patients are very comfortable being flat. And I think it's pretty common in New York for patients to go flat. And we really respect that. But I think what's important for patients to know is that there is a national law in the United States mandating that insurance companies pay for reconstruction. And that not only includes reconstruction for the side with the mastectomy, but also for what we call a symmetrizing or a match up procedure on the other side, which is very helpful for patients that may have a larger breast, they may have a droopy breast, and it can match the side with a mastectomy, and that can also be done on the same day as the breast reconstruction. So breast reconstruction surgery is painful in that it's surgery, and you will be undergoing a mastectomy in most cases for patients that are undergoing reconstruction. So there is pain associated with the mastectomy. So in my opinion, I don't think it's more painful than undergoing the mastectomy, because typically the pocket that's made is the type of surgery that's done from the mastectomy. And so there's not an additional great amount of pain added by having reconstruction. We also do a lot of implants over the muscle at Mount Sinai, which is a newer procedure. Typically, implants are placed under the chest wall muscles, which means that a pocket is made by lifting up the chest wall muscle. So that can sometimes be painful. It can give patients a sensation of stretching, especially at night. So there's a lot of interest in what we call prepectoral implants, which are implants that are placed above the muscle. And that, I think, really helps with patients' post-operative pain or post-surgical pain. And we're really seeing patients get back to normal life much faster with these types of implants. So that's an excellent question, because I think patients have a lot of fears about a recurrence of breast cancer. And the most common site of recurrence after a mastectomy is in the skin. And that's very easily appreciated with any type of reconstruction. So what you're looking for is a little bump, and most patients notice this by themselves. And it can be pink, it can be white. And usually patients will say, I noticed this about 3-4 weeks ago, and then it started to get bigger, or there started to be more of them. And then they'll come and see us in the office, and it has to get biopsied. So breast reconstruction really doesn't mask that, because the skin is all pushed forward with breast reconstruction. So I really think that it's absolutely safe, and we have lots and lots and lots of data and studies showing us that breast reconstruction after mastectomy or after lumpectomy is perfectly safe. So recovery from breast reconstruction surgery, it depends on the type of reconstruction you have. If you have an implant-based procedure, meaning a tissue expander or an implant placed at the time of the mastectomy, you're going to stay 1 night in the hospital, which is the same as if you were to go flat after mastectomy. So usually we keep patients 1 night in the hospital just to make sure your pain is controlled, make sure you're able to walk around, and make sure that there's no bleeding. Reconstruction using your own tissue, it depends on the type of what we call flap or the tissue that's used. So the most common type of flap that we do at Mount Sinai is called a DIEP or deep flap. And that's what I was talking about before with taking the fat from the belly. Usually patients stay 2 nights in the hospital. Sometimes patients stay 3 nights, and it just depends on the patient. It depends on how much pain you have. It depends on how you're feeling. Often patients need physical therapy just to make sure that they're safe to go home and walk upstairs, et cetera. So that type of recovery is a little bit longer. Patients are usually out from work for a little bit longer if you do tissue from your own body. And generally we tell patients that are getting implant-based reconstruction 2 to 3 weeks out of work, and patients that are getting reconstruction from the body, usually it's more like 4 to 6 weeks out of work. But again, every patient's different, and some patients can work remotely, especially in this era of COVID. So patients often we see working remotely even in the hospital because their pain is so well controlled, and it's really not a lot of pain after reconstructive surgery.